Hey everybody, welcome back to another video of Easy A Nursing. Today, we're going to talk about the Emergency Severity Index, also known as ESI. So the Emergency Severity Index is actually a triage tool that's used in ERs across the nation. Some ERs actually have specific triage classes that they send their nurses to, and others don't. The reason that I'm making this video is because when I started as an ER nurse, I knew nothing about how to triage somebody. I didn't really know how to tell how sick they were. Well, I don't want anybody to be in that same position that I was in. So maybe your ER doesn't offer a triage course, or maybe you need a little refresher, or maybe you're a nursing student and you want to get into emergency medicine. Either way, I want you to be prepared on your next day of triage. So this video is actually an overview of the Emergency Severity Index version 4, and that's actually a manual that you can find online in a PDF. The manual has really good in-depth explanations of everything that we're going to talk about today. And it even has case studies with questions and answers that you can practice to test your knowledge. And if you want additional information about triaging patients, then check out the book, Fast Facts for the Triage Nurse. I'll put a link in the description below. So without further ado, grab a cup of coffee and let's learn how to triage like pros. The first thing that we need to talk about when we talk about ESI triage are the goals of triage. Why do we even have to do this in the first place? Why can't everybody just waltz into the ER, take whatever bed they want, ask for a turkey sandwich, get a blanket, sleep there all night, and go home in the morning, right? Wrong. The triage nurse will stop you, and here's why she's going to stop you. The first goal of ESI triage is to identify which patients should be seen first. The second goal is to consider what resources each patient actually needs. And the third goal is to identify which patient is most urgent and to maximize patient streaming. Now, what do we mean when we talk about patient streaming? Are we talking about a bunch of patients sitting on their cell phones, looking at YouTube videos, watching cat videos, watching this video? No, we're talking about streamlining patient care. That way we can get the right patient to the right place at the right time so that they can get the right resources they need to be taken care of. So when we talk about ESI triage, we talk about triaging people based on a numerical system. And those numbers go from 1 to 5. 1 is the most critical patient. We sometimes call these patients immediate. If you're in a color-coded ER, you might call them blue. And 5 is the least critical patient, and it's also the patient that requires the least amount of resources. So every nurse has to make decisions, right? And your triage nurse has to make decisions all day long. The first decision that the ESI triage nurse has to make is if this patient requires life-saving intervention. Now you might be asking yourself, what are some life-saving interventions? Well, I've listed a couple here. Are we worried about this patient's airway? Are they going to occlude their airway? Are we worried about having to give them emergency medications, epinephrine, adenosine, things like that? Or are we worried that they might need hemodynamic interventions? Now, we're not just talking about IVs here, right? Anybody can get an IV. An abdominal pain patient can get an IV. We are talking about emergency hemodynamic interventions. So your intraosseous device, an ART line, a central line, things like that. So that covers the list of things that might qualify as immediate life-saving interventions. A patient can also qualify as an ESI Level 1 if they are intubated. Are they apneic? Are they pulseless? Are they in severe respiratory distress? Are they unresponsive? Now you might be asking yourself, what does it mean for a patient to be unresponsive? So I put a couple definitions here to help. An unresponsive patient is nonverbal and they don't follow commands, or they require a painful stimulus. So does the patient require a sternal rub? Do they require a trapezius squeeze? Do they require excessive nail bed pressure? If the answers to any of these questions are yes, then the patient should be triaged as an ESI Level 1. So what does an ESI Level 1 actually mean? It means that the patient is unstable and they could die without medical intervention. For this reason, the doctor and the nurse must be present immediately at the bedside. So when I started in the ER, it was actually kind of difficult for me to differentiate between what was life-saving and what was non-life-saving. So I wrote out some examples for you guys. The first one we'll touch on is airway. So a life-saving intervention would be bag valve mask ventilation. Do they have a respiratory rate of 5? Do we have to bag this patient to assist with their ventilations? That counts as life-saving, ESI Level 1. Do they need to be intubated? Do they need a surgical airway? Is there so much swelling up top? Is their tongue the size of their mouth and you can't even intubate, so you have to crike them? Do they need emergent BiPAP? Then non-life-saving on the other side would be, is their sat 88% and I can put them on a nasal cannula at 2 liters and bump it up to 94. That counts as non-life-saving. Also, even your non-rebreathers, those count as non-life-saving interventions. Now for circulation, does the patient need defibrillation? Do they need external pacing? Do they have a heart rate of 35 and they're pale and diaphoretic and we gotta slap those pads on until we can figure out what to do and get them a permanent pacemaker? Does the patient need emergent cardioversion? Are they an SVT? Do they need significant IV fluids? Do they need significant blood administration? Do they need blood administration? Do we need to control some massive hemorrhage? Are they bleeding out internally because they were in some major trauma? That counts as an ESI Level 1 because it falls in the life-saving category. Even intraosseous devices count as life-saving interventions. Think about your coding patients. Your patients come in code blue with EMS. Often they have an IO because EMS couldn't get a line in the field, right? That's life-saving. Then on the other side of the circulation, the non-life-saving, do they just need a cardiac monitor? Do they just need some IV fluids and some IV access? That doesn't count as life-saving. But if you come down here to meds, do they need Narcan? Did they overdose on their oxycodone that they took every 5 hours because they have chronic back pain? Do they need D50? Do they have a sugar of 20? Do they need dopamine, adenosine, atropine? Non-life-saving meds, do they need aspirin? IV nitro, that doesn't count either. Antibiotics, heparin, even your respiratory treatments like your albuterol nebs, they don't count as life-saving interventions. All right, so now that we know what's life-saving and what's non-life-saving, let's look at some examples of ESI Level 1s. Your cardiac arrest patients, your respiratory arrest patients. Like I said earlier, these are your code blues. Does the patient have an SpO2 of less than 90% and we anticipate needing to intubate them or put them on emergent BiPAP or CPAP? These really bad CHFers and COPDers, sometimes they call EMS and they're out in the middle of nowhere and their SATs are 68% on their 2 liters nasal cannula that they always wear. EMS throws them on CPAP. That counts as an immediate life-saving intervention, and that person is an ESI Level 1. Is the patient an overdose with a respiratory rate of less than 6? Is the patient in anaphylactic shock? Did they eat that peanut butter cookie that they really just love, even though they're allergic to it? Did they not know they were allergic to peanut butter? Is the patient hypotensive? Do they have signs of hypoperfusion with that hypotension? Also note that a flaccid infant here counts as an ESI Level 1. Last ESI Level 1 that I have up here, a chest pain patient who is pale, diaphoretic, and hypotensive. What are we thinking? STEMI, right? Most ESI Level 1s are admitted to the ICU. Some do die in the ER, and then maybe if they have a reversible condition, we'll discharge them home. So now let's move on to ESI Level 2s. So here we come to our second decision point. And the second decision that you need to make is really, can the patient wait? Can they wait in the waiting room for an hour, 30 minutes? Can they not wait in the waiting room? And how you come to this decision is you ask yourself these questions. Are they high risk? Are they confused? Are they lethargic? Are they disoriented? Or are they in severe pain or distress? Now let's go over what a high-risk patient actually is and who meets the qualifications to be considered a high-risk patient. So if someone is high risk, what it means is they have a condition that could easily deteriorate. To be considered high risk also means that the patient could have potential threat to life, limb, or an organ. So high risk patients do not get a detailed triage assessment, and sometimes these patients don't even get a full set of vital signs. The patients that are high risk are the ones that you're really going to want to initiate your triage protocols on. Get an IV, get an EKG, give meds if you need to, draw labs, things like that. For example, your chest pain patients, if you suspect them of acute coronary syndrome or ACS, but they're stable, they get considered a high risk and a level 2. If somebody has signs of a stroke, they're considered high risk. If somebody is a rule out ectopic pregnancy, they're also considered high risk. Now our suicidal and homicidal patients, they're also high risk. They're a risk to themselves, they're a risk to us. And then the immunocompromised patient, so somebody that's on chemotherapy and has a fever, they also get considered high risk as well. Now let's talk about the patient that's confused, lethargic, or disoriented. For example, some kind of new onset of confusion in an older person. Maybe a mother brings her 3-month-old baby to triage and says, they're only sleeping all day, they're not doing anything else. Maybe it's a teenager who has a new onset of confusion as well. Maybe they're disoriented. Could it be meningitis? Could it be drugs? They're considered a level 2 either way. So now let's talk about the patient with severe pain. So technically with the ESI Triage Algorithm, you can up triage a patient to a level 2 if they have a pain scale of 7 or greater out of the 1 to 10 numeric scale. Now, I'm sure that your physicians are really gonna love this. They love it when nurses upgrade triages to level 2 based on pain. But if you really truly believe that the patient is in that kind of pain, you're allowed to upgrade the triage. So you don't have to upgrade the triage to a level 2 if they have a greater than 7 out of 10 pain, but you can. So really you should look at pain that alters vitals or appearance. Do they have an increase in heart rate? Do they have an increase in blood pressure? Are they diaphoretic? If you really think the patient is in that severe of pain and their heart rate is 120 and their blood pressure is 170 over 115 and they're diaphoretic and sweating all over your triage area, then you feel free to upgrade them to a level 2 based on their pain. For example, let's take that kidney stone patient. They come into triage and they've got severe right flank pain and they're pale and they're diaphoretic and they're vomiting and their pain's an 8 out of 10. You go ahead and upgrade their triage to a level 2 if you want to. So the question you need to ask yourself when you're deciding if this patient meets ESI level 2 triage criteria is, would I give my last open bed to this patient? If you would give your last open bed to them, then make them a 2 and bring them to the back. Just another little fun fact here, 50 to 60% of ESI level 2s are admitted to the hospital. All right guys, so let's move on to the ESI level 3. So if you're going to triage somebody as an ESI level 3, it means that the patient is not high risk and that they are stable. So now we're coming to decision number 3, and decision number 3 is resources. So how many resources is this patient going to use? If the patient's going to use 2 or more resources, then we're going to call them a level 3 or a yellow. If they're going to use only 1 resource, then we call them a 4 or a green. And if they're not going to use any resources, then we qualify them as a level 5. And I'm actually not sure what color level 5 is, but let's go with brown. So if we're going to triage a patient based on the number of resources they're going to use, then we should know what is a resource and what is not a resource. So I've listed out on this board the things that count as resources and the things that don't count as resources. So your resources, these are your labs. It could be a pregnancy test. It could be a urinalysis. This could be your CBC, your CMP, any kind of blood work, blood cultures, things like that. Then we count EKGs. Any imaging, so your x-rays, your CTs, your MRIs, your ultrasounds, they all count as resources as well. Next, we include IV fluids. Then we can also count IV, IM, and nebulized meds. So your albuterol breathing treatments, those count as resources. Specialty consults are also on the list. So maybe we need a consult for gastro, maybe we need oncology, maybe the patient needs a surgery consult because they need an appendectomy. Next, we include simple procedures. So these are laceration repairs, and a simple procedure counts as 1 resource. However, if you look on the bottom right here, complex procedures, so reductions, things like that, those count as 2 resources actually. Then I have things that are not resources. So your point of care testing, maybe it's just a finger stick, that's not a resource. Maybe you guys can do eye stats in your ER, those are not resources. Then we look at IV insertion. Just putting an IV in somebody, that doesn't actually count as a resource. PO meds, your tetanus shot, those don't count as resources. Can you imagine if every laceration patient who counted as a simple procedure and got a tetanus shot had to be called a level 3 because a tetanus was a resource? So then the last two things on the list that are not counted as resources are crutches and splints. Splints take a lot of time, but they actually don't get to count as a resource. Now up here I have listed an example of a level 3 patient. So say a 30-year-old female comes into your ER, she has right lower quadrant abdominal pain, she's nauseous, her vital signs are stable, she's afebrile. She's going to count as a level 3, right? Because she's going to get labs, that counts as a resource. She's going to get IV fluids, that counts as a resource. She's going to get IV meds, that counts as a resource. And what if she gets a surgery consult? What if this is appendicitis? So she's already got 2 or more resources, so we qualify her as a level 3. So now we can get to decision number 4, and decision number 4 is vital signs. So vital signs are important, but they're not always helpful to determine somebody's acuity level. Now, what do I mean when I say that? Sometimes you'll know if somebody's a level 1 or a level 2 just based on their complaint, their medical history, and their appearance. And for these patients, we actually shouldn't even stop to get vital signs in triage. If you think that the patient is a level 1 or a level 2 based on their appearance, you need to be calling up your charge nurse and getting a bed in the back. But like I said, vital signs are actually important because sometimes you won't know if somebody's a level 2 just based on their complaint history. So for example, say an 85-year-old man comes in, he's complaining of dizziness. He initially looks fine other than his complaint, and then you slap the pulse ox on him and his heart rate is 30. And you're over there sitting verifying with the radial pulse and his heart rate is actually 30. These are the patients that you need to upgrade their triage level, call your charge nurse, and get them to the back to be seen. Now there are some vital signs to consider. The vital signs that we consider when we're debating on whether we should upgrade somebody's triage level are heart rate, respiratory rate, SpO2, and temperature if the patient is less than 3 years old. So down here I've actually put some danger zone vital signs with the age, the heart rate, the respiratory rate, and the SpO2 for all of these patients. So if you have a 2-month-old and the heart rate's 185 and they're breathing 56 times a minute and their SpO2 is less than 92, you should consider upgrading their triage level to a level 2. Now, that being said, the patient does not have to meet all of the criteria for heart rate, respiratory rate, and SpO2 for you to upgrade their triage level. Consider one of them, consider if they're sick, and upgrade the level. Then we look at 3-month to 3-year-olds. So if their heart rate's greater than 160, if they're breathing greater than 40 times a minute, and if their SpO2 is again less than 92, these are danger zone vital signs. If somebody's 3 years to 8 years old and their heart rate's greater than 140, their respiratory rate's greater than 30, and their SpO2 is less than 92, they meet danger zone criteria again. And last but not least, for anybody over the age of 8, consider their heart rate. Is it greater than 100? Their respiratory rate, is it greater than 20? And their SpO2, is it less than 92%? Now let's do a quick recap. So when you triage somebody according to the ESI Triage, you need to decide if the patient's a level 1 or a level 2. So remember, level 1, are they apneic? Are they pulseless? Do they need immediate life-saving care? Or are they a level 2? Should I give my last bed to this person? And like we said earlier, you can tell that based on the complaint history, based on their medical history, things like that. And if the patient's neither a level 1 nor a level 2, then you should count the resources that the patient's going to need. If the patient needs 1 or no resources, you triage them as a level 4 or a level 5. And actually, here's the crazy thing. You don't need to get vital signs on these patients. Isn't that amazing? When I first heard that, that blew my mind. Now, if the patient requires 2 or more resources, then you need to look at their vital signs. If there are any danger zone vital signs present, consider upgrading them to a level 2. That being said, you don't have to upgrade the patient to a level 2. Technically, if the patient's over the age of 8 and their heart rate's 102, that counts as a danger zone vital sign. Do you have to? No. Now before we close today, let's look at vitals and pediatric fever. So for children, you should always be taking their vital signs at triage, even if you think they're a level 4 or a level 5. Sometimes pediatric fevers can signal sepsis and bacteremic children. And do you really want to send a septic child up to the fast track area? Your providers and mid-levels will be so upset with you. Let's take a look at fever guidelines in pediatric children. So if a child is 1 day old to 28 days old, you should triage them as an ESI Level 2 if they have a rectal temperature of greater than 100.4. That is our official cutoff mark for a fever. And remember, you should always be taking these temperatures rectally because the core temperature is, of course, the most accurate. They don't really give us any guidelines, though, between the ages of 1 month to 3 months old. But you should consider upgrading them to a Level 2 if their temperature is greater than 100.4. And really, when I think about this, I think the reason that they say this is because children's immune systems are not completely developed until 3 months of age and older. If the patient is 3 months old to 3 years old, you should follow these guidelines. You should triage them as an ESI Level 3 if their temperature is greater than 102.2 and they have incomplete immunizations, or you have no idea what the source of the fever could be. You should triage them as an ESI Level 4 or 5 if their immunizations are up to date and they have that temp 102.2, or if they have an identifiable source of the fever. Now, say mom brings in her 3-year-old child and he's got a fever of 102.3 and he's been pulling at his ear all day, and you look in his ear because you happen to have an otoscope up in triage, and triage is super slow, and the tympanic membrane is red. That is an identifiable source of a fever. You think the kid has an ear infection. Go ahead and triage him appropriately as a 5 because he's just going to get oral antibiotics, right? And put him up in the fast track area. That's 100% appropriate. Hey everybody, welcome back. Thanks for watching. If you found it helpful and wouldn't mind showing it, hit that like button down below. And if you never want to miss another video from me, then hit subscribe so you're notified every time that I post. So before I leave you today, I just wanted to let you know that there's actually a whole section of the ESI manual that I didn't even cover. It touches specifically on pediatrics and goes way in depth. If you want to see that video, then comment down below in the description. Otherwise, thanks for taking time out of your day to watch my video. I'll see you next time.